Before I go on to the unknowns, I also just want to mention that some of these unknowns some of them were prepared for another conference here in Chicago. So I'd like to acknowledge that some of the cases involved work by my fellow in residence. I'd like to acknowledge Anup Hazra, Steve Zangin, and Taylor Stroud, who helped prepare some of these cases. First case, 22-year-old, status post-total colectomy with anostomy, placement for severe Crohn's disease, nausea and vomiting for 1 day, fever, chills, assessed for abscess or obstruction. Start off with a plain film of the abdomen. That was the history. And some gas seen in the small bowel. Is that small bowel normal? No. Folds are thickened, right? And there's also, the bowel is what? Relatively central in location. I mean, I would certainly wonder a little bit whether there was also ascites. There's a nasogastric tube in place. So we have some dilated small bowel. There's really no colon there. And let's see what else is going on. Now the patient had a CT scan. Here's the top cut. I'm going to help you a little bit because as I show you the rest of these, what's going on? Right, SMV thrombosis. So the patient has actually developed thrombosis involving, here's the confluence. This is splenic vein. This is the confluence. And if we go back to that previous cut, you could actually see that these are hepatic veins. So these are intrahepatic portal veins that actually have thrombus. So the thrombus is propagated to involve both intra and extrahepatic portal venous system and superior mesenteric vein. And as we go further down, you can see the continuation of the superior mesenteric vein containing that blood clot. You can actually see the dilated small bowel. So there may be secondary ischemic changes maybe in the small bowel. There's ascites and small bowel dilatation, which correlated with plain film findings. This acute thrombus involving the portal and superior mesenteric venous system with secondary changes. As we go involving the small bowel, here we continue down, you still see the ascites, the dilated small bowel, and the thrombus propagating actually into the jejunal and maybe even the ileal branches of the superior mesenteric vein. Just to go down a little bit further and show you a little bit more of that. And back here's the ostomy that we know the patient had because of the previous surgery. And here the more dramatic cut that I showed you before, showing the thrombus at the confluence. So SMV portal thrombosis, it is often not discovered until there's some other abnormality unless it's extensive and presents acutely with acute pain, but sometimes discovered due to the GI hemorrhage. It may present with abdominal pain, the portal system changes due to some other entity, encephalopathy or GI hemorrhage due to varices, splenomegaly or ascites in patients who may have, let's say, cirrhosis or some other underlying process involving the liver. It's a whole variety of entities that can cause it, and that includes pancreatitis from the talk given previously by Frank Miller, ascending cholangitis from the talk given by Dr. Barron, intra-abdominal sepsis, etc. So you could see, depending on the entity, hepatosplenomegaly, an enlarged azygos vein, or paraspinal varices. Again, depending on the cause. The filling defect would be nicely demonstrated on the redistribution phase in the portal vein. Sometimes you accidentally scan too early. You're very early arterial phase. You don't have good filling in the portal phase. You might miss thrombus then, so be careful. I don't know if you routinely do delayed images of the kidney, but if you do, it always affords you a second chance to look at other structures and see a later phase in washout. It can be helpful for the veins, like the superior mesenteric vein and portal vein. It can be helpful for the liver when you have unsuspected cardiac disease and a long circulation time. In angiography, you might see acute or partial portal vein thrombus. A filling defect can be seen on a late phase or an SMA arteriogram. Certainly, you might see signs of cirrhosis, or you might see signs of enlargement of the portal vein with partial or complete thrombus. So the clot might be visible. The clot itself might be hard to see. I think most of us, even if we're not doing a Doppler exam, normally turn the Doppler on to measure the common bile duct. While you're doing that, don't forget to look at the portal veins. Very useful, particularly in patients with cirrhosis, and make sure there is no thrombus in the portal vein. It sort of gives you a little second look. And even that's how I do it. I mean, and that's how my tech does it. We don't go in the room in every case, but I think when you have a patient, certainly with cirrhosis, it's useful to note the portal vein, even if you're not doing it for Dopplers. Okay, case 2. Remember, you're in a football game. I want to hear some nice loud yelling. Middle-aged male with abdominal pain, real histories. Whether they're true or misleading, they are real histories. Excellent. Somebody said abnormal transverse colon. So let's see. I'm not sure I want to point it. Here's the stomach, which is okay, right? I don't know if you could see there's something over here. You can actually see a little scalloping or a meniscus sign over here. I'm sorry I did not bring the virtual colon. This was actually an attempted insufflation done for virtual colonoscopy. And this distended colon is therefore manual insufflation. See if we can outline in this intussuscepting mass, very large mass, smooth. So what do you think is causing it? Duplication's one idea. What would be the most common cause of a colocolic intussusception? Right, lipoma, right? Certainly be the most common. And here you can see on CT the intussusception. We saw in the previous lectures some examples. Claire showed you some intussusceptions in the small bowel with CT and barium, and the same concept over here. You might see the mesenteric fat being pulled in, and depending on whether you're catching it in cross-section or in profile, it may take a variety of appearances. But in this case, you can actually see the lipoma. So as we said, colonic lipomas are the most common causes of submucosal masses in the large bowel. 90% occur in the colon. 75% of the colonic lipomas occur in the right colon. They're usually asymptomatic and small, but when peristalsis goes through a lipoma, because it's soft, it stretches the overlying mucosa. Now, obviously, in the colon, you're dealing with colonic peristalsis, which are these large intermittent waves that propel stool, whereas in the stomach and the small bowel, you're dealing with more frequent peristaltic waves of a different physiologic type. But in either case, therefore, these lesions can start out as classic submucosal masses, like the one I showed you in the stomach, but then develop a pedicle. Okay, and then that pedicle that mass will then serve as a lead point for intussusception. The reason they get the GI bleeding is because either they stretch the overlying mucosa, which causes ulceration, or because they develop an intussusception, which interferes with the blood supply and then causes ischemia of the adjacent bowel or overlying bowel, and then causes GI bleeding and obstructive pain and symptoms. So this would be the pathophysiology. Case 3, an elderly male, weight loss, melanin, abdominal pain. Show you a few images. The true history actually is there actually was some previous surgery, but it doesn't really matter. CT scan, oral and IV contrast. I think everybody sees that there is some sort of soft tissue mass. You might be wondering whether there's possibly an intussuscepting mass here. It certainly has a large lobular mass involving the transverse portion of the duodenum, and on the images a little bit further down you can see a little low density that sort of looks like fluid in the lumen, maybe some contrast getting trapped. So hard to tell, but it is in the distribution of the third portion of the duodenum. So what sort of things would you put in your differential diagnosis? Well, think about Claire's lecture. What's the differential for masses in the small bowel? And try to tailor that differential down and ask yourself what it might be in the duodenum. Now, certainly masses in the duodenum are uncommon to start with. I mean, most of the masses in the duodenum are small things like ectopic pancreatic rest, but you could certainly get carcinoid, lymphoma, metastatic disease. Adenocarcinoma in the small bowel is an uncommon entity. When it occurs, it can occur in the duodenum or proximal jejunum, more commonly than in the distal in the ileum. But anything that the wall is made out of can become an oma. So all the other entities that we talked about in the previous lectures, and this actually is a gastrointestinal stromal tumor, but involving the duodenum, and the degrees of malignancy in those tumors can be quite variable. So the differential might include of a small bowel mass around the duodenum, make sure it's not coming from the pancreas, things coming from the lymph nodes, from the bowel wall itself, including lymphoma and spindle cell tumors. Okay, there was another slide I left it out for this purpose. That's fine. Case 4. a young woman with abdominal pain. Here's a T1 weighted image. This gets back to a lot of lectures by Frank Miller, maybe a little bit by Dr. Barron, I think mostly Frank's lecture. So on T1, I think you might be able to make out that there's something in the liver here. We'll come back to it. So on T1, it's primarily hypointense with liver, although there is a thin hypointense rim on T1. Here's T2. CSF is nice and bright. And this lesion is big, but it's not particularly bright. It has certain little septations that might be bright, but the lesion clearly has different character and has different intensity than the surrounding liver. You're biased a little bit by the fact that it's a young woman. So what sort of things might you include in the differential considerations? Adenoma. What else? FNH, right? You might look for a central scar. Now, you don't have to see a central scar in every FNH. Here's the early arterial phase. Here's a late arterial phase. Does that help you? So the lesion on the arterial phase is enhancing, right? It's enhancing with some heterogeneity, but pretty much the whole thing is enhancing. You don't really see a definite central scar and washing out a little bit, but still retaining some of the contrast on the late arterial phase, certainly not acting like a hemangioma. Might have a little compression effect even on the IVC here. Right, so the differential considerations, I think in this case you would probably put adenoma, FNH higher on your list. You might include HCC, which can have quite a variable appearance. But A, there's no signs of cirrhosis, and HCC in the patient who has no cirrhosis would be unusual, or it certainly can have Hep C HCC without actually truly having cirrhosis. And it didn't really have the characteristics of a hemangioma, certainly not a cyst. And METs can have varying vascularity. If the patient had a known primary, I think you'd certainly have to consider metastases. But a young woman with no known primary in that pattern, I'd put FNH and adenoma highest on the list. Ask if the patient, would use birth control pills that might help. This turned out to be an FNH. So the MR features usually iso-intense, and they're nearly so on T1. T2 could be iso-intense or a little bright with early arterial enhancement. And those were the features we saw in this case. 75% are found in young women. Similar density, intensity, and on ultrasound, echogenicity to surrounding liver can sometimes be hard to see. On ultrasound, they can be, usually I found them to be hypoechoic relative to surrounding liver, unless the patient has bleeding. Sometimes FNH is kind of bleeding in it, but more commonly if you see bleeding in it, that would be an adenoma. It's certainly the third most common benign liver lesion. Central scar, in fact, is not seen in all cases, maybe only 20%, and Frank talked about the features of the fibrous scar. You may see increased uptake on sulfocolloid. They do not calcify. They're usually unifocal and small, but they can be large. Multifocal would be uncommon, as opposed to the adenomas, which can be multifocal, particularly in patients who have glycogen storage disease. Malignant degeneration has not been reported in FNH. Case 5, right upper quadrant pain and fever. First study the patient has is CT. Amazing that there's a history. The history was actually obtained after the CT. Isn't that usually the way it works at your institution? No? Excellent. All right. The football game is in the third quarter. The crowd is getting rowdy. I love it. Emphysematous cholecystitis. When asked if the patient is diabetic, you can actually see air in the gallbladder. Couldn't the gallbladder be hydropic in cholecystitis? Well, no, not necessarily in emphysematous cholecystitis, and certainly not if the patient is actually perfed. There's already fluid, and there's maybe been perforation, so the distension of the gallbladder may not be present. And in emphysematous cholecystitis, most of these patients are diabetic. The gas can occur both in the gallbladder wall and in the lumen of the gallbladder. Very often, people will show that as an unknown on the plain film. You'll see a nice round circular gas collection or ring-like gas collection in the right upper quadrant, and it gives you the differential for gas collections in the right upper quadrant, including abscesses in the distribution of the gallbladder or in the liver or subhepatic due to a variety of causes or air in the gallbladder. Now, you can have air in the gallbladder due to other things. Right, so a trick case would be if somebody just underwent an ERCP, right, and there's air, or if the patient had surgery and had some sort of choledochoenterostomy, you can get air in the gallbladder. So remember, there's always a differential. Think about those things if you're doing sort of unknown cases, abort cases. So emphysematous cholecystitis is 75%. Is that right? Calculus. I should probably say acalculus. I think most of those are, or many of those are acalculus, isn't it? The Clostridium is often cultured. Patients are often diabetic, greater than 50 years of age. And while the patients may have stones, I think that's incorrect. The pathophysiology that's thought to be present here is that the blood vessels are abnormal in the diabetics, and therefore there is some abnormality. It's almost like an ischemic event to the gallbladder. The differential diagnosis, as we said, includes enteric fistula, ERCP, and maybe a localized duodenal perforation. Case 6, young woman with questionable liver lesion. Seen on a recent CT, she is now asymptomatic. So I'm showing you a T1, T2 weighted image through the liver. On T1, I think everybody sees the lesion. The lesion is hypointense on T1, fairly well marginated. And on T2, is it a little bright or very bright? Very bright. So it's as bright as CSF. And is it homogeneously or inhomogeneously bright? Homogeneously bright, right? And what happens when we infuse? So this should be a what? Hemangioma. Wait a minute. So let me ask you. So in a hemangioma, don't you get complete fill-in? Why is there a little area that's not filling in? Does that sway you away from hemangioma? No, it does not, right? So it should be hemangioma. And hemangiomas become about 3 centimeters or larger. They may get some central fibrosis. So while the classic description is certainly cotton wool, fluffy peripheral enhancement, so it's slow in and slow out, right? As opposed to HCC or vascular metastases, which is, fast in, fast out. This is a bit slow in, slow out. So you get some enhancement early on. You do a little bit later phase. You might see a little more enhancement and then fill in. And if you do delayed images, it should wash out very slowly. But the central fibrotic areas will not fill in. And don't let that sway you away from hemangioma. The bigger the lesion is, the more likely it is to have areas that don't fill in on delayed images. So differential, well, on the T2 there certainly could have been a cyst, hemangioma, necrotic cystic tumor. Obviously, the contrast enhancement is critical. Hyperintense on T2, look for other organ involvement in various syndromes, such as Osler-Weber-Rondeau, etc. And other syndromes that may have, such as Kippel-Trinani-Weber, might have multiple hemangiomas. Okay, case 7, 51-year-old female, nausea, vomiting, and pain. I don't know about your ER, but that's a history on every patient that comes to me from my ER. What went wrong? The ER didn't do a CT first. Oh, my. Case 7. Okay, so what's going on? Volvulus. This is the most gorgeous case of volvulus given to me by my colleague at the University of Chicago, Arunas gastritis. And you can see the stomach is totally flipped. And basically think about the axis of the stomach. Gastric volvulus is defined based on its location relative to the diaphragm and relative to the axis of rotation. So subdiaphragmatic, about 1/3 of the cases, and not associated with diaphragmatic defects. Supradiaphragmatic, 2/3 of the cases can be associated with diaphragmatic defects. So remember I showed you the CT of the partial intrathoracic stomach. When you get like a complete intrathoracic stomach, there's always a mixed volvulus associated with those intrathoracic stomachs. And it's really usually of no clinical significance because those mixed volvuluses that are associated with intrathoracic stomach hiatal hernia are usually asymptomatic. That's why I emphasize the pure paraesophageal hernia. But when there's no hernia present, and these are subdiaphragmatic, those patients, it's important to differentiate the type of gastric volvulus because that will determine whether the patient has symptoms and interference with the blood supply or not. So you think about the axis of the stomach as the axis of rotation. If it rotates along the axis of the stomach, that's organoaxial volvulus. If it rotates 90 degrees to that, so that sort of the pylorus goes up to where the EG junction should be, that would be a mesenteroaxial volvulus. So organoaxial is the slight majority of the cases. The stomach rotates along the longitudinal axis of the line connecting the cardia and the pylorus. Greater curvature is flipped medially in vertical stomachs and superior to the lesser curve in transverse stomachs. as in this case, more commonly associated with strangulation, and on 5 to 28% of the cases, a rich vascular supply of the stomach might be interfered with. So in the mesenteroaxial, which is about a third of the cases, the rotation is in the other direction, so the antrum is flipping up. So you rotate about a vertical axis through the middle of the greater and lesser curvatures. You can have a right-left or a left-right or a right-left rotation. So the pylorus moves anteriorly and superiorly, and the greater curve remains inferior. So this is more often young children, maybe associated with ligamentous laxity. Case 8, going into the fourth quarter. 74-year-old male with abdominal pain. I don't know how much oral contrast got through, but some of this is the true history. I mean, the patient did have oral and IV contrast. So a couple of images from the CT show profound, obvious abnormalities. I think you can all see that there's ascites, and the small bowel is abnormal. So is the small bowel focally abnormal or diffusely abnormal? Diffusely abnormal. So is it, which pattern would you put it in? Is this thick folds, nodular folds? Mixed? So these are thick folds, right? And so even though Claire showed you the idea of analyzing folds on a small bowel series and on an enteroclysis, but the same process would apply to a CT scan. So pick a fold and follow it. Ask yourself if it's nodular or if it's just uniformly thickened. So these are uniformly and markedly thickened folds involving the small bowel, both jejunum, if you had all the images, jejunum and ileum are involved. And in fact, the colon is involved as well. And there's ascites. And this is ischemia. I should have asked you for a differential. So this is a patient with ischemia. Certainly, you want to think about ischemia. I mean, in the patients, if you just saw a small bowel thickening, there's a long differential, including any kind of enteritis, including infectious enteritis. But those patients don't usually get severe pain, and they don't usually get that much ascites. Whereas if you're seeing ascites in association with small bowel thickening, you want to think about things that will cause fluid to leak. Patient's profoundly hyperproteinemic, and if the patient has pain, think about ischemia. So the sine qua non of ischemia is abdominal pain out of proportion to the other clinical findings. Always think ischemia when the patients have bad pain. The caveat to that, and actually I've seen it as a very important caveat, is patients who are on pain meds, patients who are on steroids, and the extreme elderly. I've seen cases of colonic perforation, go to perf where surgeons didn't necessarily want to operate because the patients didn't have a lot of pain, weren't really thinking about ischemia. So when you see submucosal edema and findings like that, be it on a barium enema, CT, upper GI, whatever, sometimes you need to know when to push a little bit. And always ask a little bit more about the history and whether the patient's on pain meds or on steroids that might mask the pain of ischemia. So it certainly can involve small and large bowel. It can be segmental or diffuse, partial, mural, meaning only the mucosal, submucosa, with or without parts of the muscularis may be involved, or transmural. And if it's transmural, it will lead to continuous necrosis of the layers and ultimately infarction. If you're going to wait until you see intramural gas or free air before you suggest that this patient needs some surgical correlation and possible surgery, you're pretty much just saving the cases that are going to die on the table. Right? So you have to know when to suggest ischemia rather than wait to see all the signs of gangrene. And again, truly clinical correlation. Now, this is also a hyperperfusion shock bowel, and I know there's been some oral contrast, but the oral contrast didn't get very far. And the IV contrast, what it does, it's kind of hard to differentiate what's really the oral and what's the IV contrast. I suspect that some of this brightness is actually the IV contrast, and what it is this hyperperfused bowel. So the IV contrast, when you catch it just in the right phase, is just sort of hanging out. So you see this pattern of hyperenhancement. And that hyperenhancement isn't hyperemia, and it's not really hyperperfusion. It's just, slow flow going through there and reduced arterial perfusion after vasospasm of the mesenteric arteries or reduced flow, venous outflow due to contraction of the mesenteric veins. And remember, there's a whole host of causes for small bowel ischemia. I mean, this can be embolic phenomena. This could be low flow. It could be malignant emboli, bland emboli, septic emboli. You can have volvulus, things that will occlude both the artery and the vein, venous thrombosis due to hypercoagulable states. So you want to think about those about half a dozen entities in the spectrum of various causes for small bowel ischemia, or bowel ischemia in general. Case 9, 59-year-old female, abdominal pain, elevated bilirubin. Is a fat suppressed. SG post-GAD. I'm sorry? Great. University of Chicago resident. Colic. This is cholangiocarcinoma. So we see some dilated bile ducts. There's a little ring-like area with a little intense focus, very centrally within the liver. Looks like to me like it's almost going towards the caudate lobe. And on the thick slab MRCP, you can actually see stricture involving the proximal right and left bile ducts. And this is your classic Klatskin tumor, cholangiocarcinoma. So again, to reiterate what I think you learned about in the lectures, certainly a malignant tumor, the biliary epithelium. It's uncommon in general, but they are usually adenocarcinomas, usually poor prognosis, about a 5% 5-year survival, usually seen in older patients with a slight male predilection. And they could take a variety of forms. They could take a polypoid form, an infiltrative form. It could look like an apple core lesion, or it could look like a focal mass. Unless you catch them very early, really uncommon to catch these very early anywhere. It's a spectrum for the biliary epithelium, so the same concept of, if you will, a cholangiocarcinoma would fall. A lot of what you know about liver cholangiocarcinoma is true of gallbladder cancer. Same spectrum of age, same general behavior, clinical behavior, same general poor response to chemotherapy and poor survival. Unless you catch it as a very early incidental polypoid lesion in the gallbladder. And that usually doesn't happen in the bile ducts. Even a small lesion tends to cause early obstruction. There's good lymphatic and vascular involvement, vascular anatomy in the biliary tree, including the common duct, and you get early spread of disease, even if you don't see any evidence of metastatic disease. Predisposing factors for cholangiocarcinoma: ulcerative colitis, sclerosing cholangitis, and less commonly Caroli's disease, choledochal cysts. I've had examples of a cholangiocarcinoma developing in a choledochal cyst, and in association with other parasites such as Clonorchis sinensis, Giardia, exposure to certain toxic chemicals. So the term Klatskin tumor is when the cholangiocarcinoma is located at the bifurcation of the bile ducts, and that's about 10 to 26% of all cholangiocarcinomas. Case 10, middle-aged male with abdominal pain. If I show you the next cut, it becomes too easy. So there's certainly some dilated loops of ileum in the pelvis. And anybody see a finding that'll... Say again? Excellent. Hernia. Beautiful. So here's the beginning of the hernia coming down the right inguinal canal, and then the next one you can see bowel and mesentery in the scrotum. So it's causing a partial small bowel obstruction. And inguinal hernia, certainly look for poor bowel wall enhancement, signs of strangulation, ascites, engorged mesenteric vessels. So while these are certainly common, obviously it would be much more important in patients who present with acute symptoms for you to diagnose the fact that there might be some ischemic or even gangrenous changes associated with a hernia of any type. This is inguinal, but obviously the whole host of hernias in the abdominal wall. Case 11, 56-year-old male with alcohol abuse presents with abdominal pain. This is just a nice example. The history kind of makes it a little bit easy, but let's just start with this. So here we are. There's something over there. What is that? Right. So those, I heard it. Somebody said varices. That's absolutely correct. So these are varices, and I just wanted to use this case to discuss unusual distribution of varices and for you to think about the pathway of collateral formation in patients with either portal hypertension or venous obstruction. This particular case is really designed then to discuss portal hypertension and cirrhosis, which Dr. Barron covered in his lecture. And just remember, there are a whole host of pathways. You'll see some very nice articles in the literature summarizing the various pathways of collaterals. The patients with what's called a patent paraumbilical vein, sometimes that vein, and this is the top cuts from this particular case, I'm going to just go back, can continue down and actually follow that draining into the right femoral vein. I was able to actually follow that all the way down. A patient has the other signs of cirrhosis: small, shrunken liver, relative hypertrophy of the lateral segment of the left lobe and sparing of the caudate lobe. and with somewhat nodular surface to the liver. The proper term for this, by the way, is a patent paraumbilical vein. We used to call it patent umbilical vein. It's not recanalization. There's another term in the literature. The umbilical vein does not recanalize. It's a collateral formation. And we talked about, Dr. Barron talked extensively about cirrhosis, so maybe we'll just cover that very quickly. Obviously, you want to look for the nodularity of the liver, change in size, look for complications such as signs of portal hypertension, splenomegaly, ascites, and look for hepatocellular carcinoma. If the patient has an elevated alpha-fetoprotein or has any signs to suggest malignancy, or that very often these patients will be followed both with checking alpha-fetoprotein and checking with triple phase studies. That could be either a CT or an MR. Very important to do that in 3 phases. Pre-infused arterial and redistribution phase to look for the lesions. Differentiating nodular regenerative nodules, which would be bright on the pre-infused due to their iron content. Differentiating areas of fibrosis and differentiating areas of confluent fibrosis that Dr. Barron showed. Case 13, 70-year-old male with vague epigastric pain. Oh, okay, maybe we'll make this the last case. I think actually, Mel, is this one that I may have showed you? So an ab lesion involving the stomach, circumferential involvement, this is adenocarcinoma of the stomach, circumferential involvement, very infiltrative, aggressive carcinoma. And here you see on the stomach on CT scan, I did not show you this image, a circumferential wall thickening involving the stomach.
I'm going to be skipping over a lot of the words on the slides. It can be a much more comprehensive lecture, and this is basically just to give you an idea of what to think about when you are looking at pelvic MR. I'm not trying to teach you how to read all pelvic MRs, but I do want to give you an idea of the things that you need to consider when you start reviewing them. So, first off, to go through some technical aspects, body coil imaging, we're going to go through the coils you can use. Using a body coil will give you increased coverage at the expense of resolution. It's useful for survey imaging, orthopedic applications, and of course in obese patients in whom the surface coils won't work. Pelvic phased array coil imaging will improve resolution, but you have decreased coverage. You have an FOV of only 20 to 28 centimeter. This is excellent for GU organ assessment, but does require normal body habitus for optimal coil placement. If the coils are too far apart from each other, you won't be getting any signal from the center of the body. Kind of an in-between option in the patients who are heavy but not super heavy is the torso coil, which can give you kind of an in-between factor. Endorectal coil imaging is for very high-resolution targeted imaging. The range of coverage is limited to one side of that coil. The field of view is very small, 10 to 14 centimeters. Some of the newer coils you can get even better. These are for targeted exams of the prostate, the cervix, rectal wall, and there are various different coils for specialized applications. Keep in mind that some patients will not be able to tolerate placement of this coil, and this is why. This is how big these coils are. The whole thing has to go in, and in someone who's got rectal disease, particularly someone perhaps with Crohn's disease, or if their gynecologic tumor is locally advanced, they may not be able to tolerate placement of this coil. Coil positioning is very important for endorectal imaging because the surface coil has this very limited range of where it's going to give you signal, and it has to really be placed right where the tumor is. Here you can see on the axial imaging, so you should always check your scouts before you start the dedicated imaging to make sure your coil is correctly placed. What sequences do we use? T1 scans. They do take more time. If you use conventional spin echo over gradient echo, the spoiled gradient echo sequences will give you a trade-off. You can do multiple necks and get it out a little faster than the T1s. These are good for your general survey of the anatomy, lymph node assessment. It complements your T2 scans for tissue characterization. T1 FAT-SAT scans and phase shift gradient echo scans can be helpful when you're differentiating endometriomas from teratomas, differentiating fat from hemorrhage, and it is used in some post-infusion applications, but T2 scans are really your workhorse. These show you the zonal anatomy of the prostate and of the uterus. It'll demonstrate follicular composition of the ovaries, and these are the ones that we rely on most heavily. The fast spin echo is faster than conventional spin echo, and by virtue of a shorter exam time and less motion artifact, it will often be of better quality. We used to use proton density imaging for differentiating serous fluid from blood, but with the advent of gradient echo fat-sat sequences, we don't use these anymore. Fat saturation can be used selectively in gynecologic applications to decrease your scan time, and I'll show you examples of when you don't need it. Post-infusion scans are not always necessary. It's not mandatory like with CT, or at least desirable like CT, but it is useful when the question is infection, bone tumor. As for use in tumor applications, we use it selectively if the T2 scans are not giving us enough information. You can use glucagon to decrease bowel peristalsis artifact. Phase encoding directions can be shifted, rotated perpendicular to the typical scanning plane if rectal motion artifact is disturbing the images. An overly distended bladder worsens ghosting, but it is useful to have some fluid in the bladder. So what we often do is have the patient void before they get on the scanner, and by the time you get to the T2 sequences, they filled up a little bit, just enough for the scan. We put superior and inferior SAT bands in place for the blood flow artifacts, and an anterior and posterior SAT band in the field of view on the subcutaneous fat will markedly decrease ghosting artifact and the effects of surface coils touching the subcutaneous fat. And I use xylocaine jelly liberally whenever I put in endorectal coils. I won't go too much into how the normal anatomy looks. I think you're all familiar with that, but just briefly, everything looks the same on T1 scans. All the organs look the same. The bladder is going to track fluid signal. The wall should be 2 millimeter or less at full distension. On T2, the prostate, the central zone will be slightly brighter than muscle. It can get heterogeneous with BPH. The peripheral zone is normally bright, and the capsule will be a dark line visible with an endorectal coil. Seminal vesicles will be fluid signal intensity with dark margins, and the urethra will be a concentric bright and dark rings. Testicles, corpora cavernosa, are moderately bright, and the bladder, again, the luminous fluid signal. The wall will be dark on T2 scans. Just quickly, normal prostate, here's T1. Notice everything's the same signal intensity. T2 scan, you can see the central zone a little darker, and the peripheral zone of the prostate is normal bright signal. This is BPH, benign prostatic hypertrophy. Notice the lobular, heterogeneous, nodular appearance of the central gland. Here you can see the peripheral zone nicely outlined and of bright signal. Seminal vesicles will be bright and serpiginous appearing on T2 scans. Notice the effect of the endorectal coil. You get good signal here, and the fluid in the seminal vesicles are very bright. Notice the signal drop off as you get anteriorly. Testes. This one's normal, this one's abnormal. These are T1 scans, proton density. T2, patient with nonspecific scrotal pain, and you can see that the normal testis is dark on T1 scans, bright on T2 scans. This is how it should look like. The T2 scans show just a striated appearance of the testis with dark signal on the T2 scans, and they weren't sure if this was infection or chronic inflammatory change, but given that the patient's symptoms abated and there was no enlarging mass on ultrasound exam, they decided there was an underlying neoplasm. And I think the fact that there isn't a delineable solid mass would also make a neoplasm less likely. So to go into some pathology, prostate cancer, MR is still not good enough to be used as a screening exam for prostate cancer, but it is often used in staging. Part of this is the Gleason grading system that the urologist will use for prostate cancer is based on histology, not imaging. There is a TNM classification for cancer, and what we look for in MR imaging is the normally bright peripheral zone will have a dark focus. Prostate cancer is dark on T2 scans. Everything looks the same on T1 scans. You look for capsular disruption, invasion of the seminal vesicles. It's very important to either do it before a prostatic biopsy or wait at least 2, if not 6 weeks after a biopsy, because hemorrhage will mess your scan up. hemorrhage will look dark on T2, bright on T1, and will make it very difficult. It can obscure tumors. Sometimes you will see a halo sign in hemorrhage where there will be a bright ring of signal intensity on T1 scans surrounding the tumor. Here's an example of prostate cancer. Here's a patient with BPH. Here's the normal peripheral zone on the T2 scan going across. As you get across midline, you get this dark area of signal intensity, and this was adenocarcinoma. T2 coronal scans showing here a straight edge. There's dark signal here. There's no capsular invasion there, but here you can see there's a little bit of irregularity, and there was focal capsular invasion on this side. And here another coronal at another level more through the midgland, and again you can see the dark signal along the edge where the tumor was. This is what happens when you get hemorrhage. This is the T1 scan, this is the T2 scan. There's a lot of heterogeneous dark signal throughout the peripheral zone here, which could be cancer, but when you look on the corresponding T1 scans, it's not all dark. There's a lot of bright signal in here from the hemorrhage, which makes it very difficult to determine how much of this is and isn't cancer. On T2 scans, prostate adenocarcinoma is dark. If it is not dark on T2 scans, think of something else. This was a patient who had a tumor in the prostate. Here you can see the mass on T2 scans. It's iso-intense on T1 scans, but it is bright on T2. As a matter of fact, it's even a little brighter than the peripheral zone. This happened to be a transitional carcinoma of the urethra. So if it's adenocarcinoma, it will be dark. Other things are going to be bright. This is the same patient with an endorectal coil, which, while you have a lot of signal drop-off as it gets away from the coil, you can still see the extent of invasion from the urethra all the way out through the gland. Here you can see the tumor. And here's another one that didn't look characteristic. It was a big tumor that was involving the prostate, the seminal vesicles, but very unusual signal. It's heterogeneous on both T1 and T2 scans. This turned out to be a leiomyoma at surgery. Here's other levels. Here you can see lower down where it is invading the prostate. And here on a sagittal scan, you can see the hydroureter that was caused by mass effect from this tumor. So moving on to the female pelvis, normal anatomy. Again, everything's kind of homogeneous on T1 scans and looks the same as everything else, but the zonal anatomy pops up on T2 with the myometrium being of intermediate signal. The endometrium will be bright, and the junctional zone between the two is a dark band. Post-infusion, the myometrium will tend to enhance more than the endometrium, but this is variable. The cervix on T1 scans looks like everything else. On T2, you look for this dark, as it's been described, a donut signal. And the vagina will also show a layered pattern on T2 scans only, with the mucosa bright, the muscularis dark, and the perimetrial area is bright again from the vascularity. The ovaries will look like intermediate stroma with water signal follicles. And congenital abnormalities are particularly well demonstrated on MR. This is one of the applications where you wouldn't want to use FAT-SAT with your T2 sequences. You can cut down time, and actually the outer margin of the uterus will be better delineated against the fat if you don't use FAT-SAT. So this is a good one to not use FAT-SAT sequences on your T2 fast spin echoes. Uterine Didelphis is complete lack of fusion of the Müllerian system, so everything's duplicated. With a bicornis uterus, you have incomplete fusion, and you will see a bilobed fundus with a deep fundal cleft. The fundal cleft is a characteristic that should be looked for. And two separate horns. It can be unicolous or bicolous depending on how many cervices are present. Here's an example of uterine didelphis. Here you can see that there is a complete separation of everything. We have two endometrial canals in the uterus, here on either side, going into separate horns. As you get down in cross-sectional imaging, here is at the level of the uterine fundus. Here you can see two separate cervical canals, and as you get down to the vagina, two completely separate vaginal canals that show the layered anatomy side by side. Here's a bicornis uterus, unicolous. The left horn has atrophied. Notice the small ovoid shape. This is kind of how a prepubertal uterus may look, and notice the narrow cavity, tilt to the right. Notice the normal ovary with the stroma and the follicles. Septate uterus happens to be the most common anomaly of the uterus from developmental abnormalities. It's incomplete fusion of the uterine horns. The uterus will be normal in contour or have a very small fundal cleft. There's a midline septum. If it is partial, it's a uterus subseptus, and it can account for a very high abortion rate. This is an example of a septate uterus. Notice this one has a partial septum. The fundus is normal contour, or maybe there's a minimal indentation, and here you can see there's a single cervical canal. An arcuate uterus is simply slight concavity of the fundus with an absolutely normal endometrial cavity and is usually of no significant consequence. The uterus may be absent or simply hypoplastic, and you may see an infantile uterus with hypoplasia where the cervix is longer than the corpus, and this would be in your adult female where you would see this pattern. It looks like she should be, 8 years old based on her uterine appearance. And then sometimes you can have just vaginal atresia where the uterus is there, but there's only a fibrous septum where the vagina should be. Here's an example of uterine hypoplasia. This was a young girl who failed to start menstruating as she was going through puberty, and physical exam showed an abnormal vaginal canal, just a very small orifice. When we did, and they could not get past, there was a membrane there, so we did the MR, and all there was this little tiny pouch, and that's all there was for uterus and vagina in this girl. So this was severe hypoplasia bordering on atresia. We can see a lot of benign pathology in the uterus. Leiomyomas, most common solid uterine neoplasm. They consist of smooth muscle and fibrous connective tissue, which accounts for their relatively low signal on both T1 and T2 scans. It's important to describe their location, as this can affect the patient's ability for carrying a pregnancy. It'll affect her menstrual cycles, whether they're submucosal, intramural, or subserosal. Malignant degeneration is very difficult, if not impossible, to diagnose with MR imaging. It's more of a matter of one of the leiomyomas growing disproportionately or suddenly undergoing acute changes in appearance. But to just get one exam and take a look at it and say, oh, that one's malignant, is not very likely to be done. Here is an example showing the 3 different types of leiomyomata in a uterus. This is an anteverted uterus. Here you can see the endometrial canal, the junctional zone. And here we have, this is the exophytic serosal type. Here we have a myometrial one, and here's a submucosal one, and another submucosal one. Same patient with different plane of projection. Sagittal views, again showing the more peripheral subserosal one. Here's a submucosal one and some myometrial ones. MR is often helpful in surgical staging, and particularly when you have a very massive fibroid uterus, as was this case. It's easy to see that all the nodules were dark on T2 scans and were fibroids. Here you can see the calcifications as areas of signal void. It's often difficult to pick up the calcifications, but when you have them, that's what they look like. And here was the coronal scan, which actually did demonstrate that the endometrial canal was somewhere buried in all of this. Adenomyosis is very nicely demonstrated on MR exam. This is when the endometrial tissue extends into the myometrium, and what it looks like is areas of low signal intensity, often just causing a localized thickening of the junctional zone. If there are bright signal foci within it, you got to think of some acute superimposed hemorrhage, which will also look bright on T1, and heterotopic endometrial tissue will be dark on T1. So here's an example of focal adenomyosis, T2 scans in the sagittal and oblique axial planes showing focal thickening of the junctional zone. This is an example of endometriosis, which I throw in the category of abnormal endometrial tissue, but this is extrinsic to the uterus, showing you T1 fat sat and T2 scans, and I'd like to bring to your attention a very subtle focus of abnormal signal intensity on the bladder dome right there. Notice it's bright on T1, it stays bright on the T1 fat sat, so it's not fat, and it's bright on T2, and this was in a small endometrial implant. On Endometriomas can get very large and complex. This was a complex cystic endometrioma. Notice all the varying signal intensities. They'll go through the whole gamut of blood signal on MR, and this is very useful to the surgeons to localize and determine how are they going to, does it need to come out, what's it involving. It helps them with the surgical planning. Just more images of it. You can see this one has debris in this component. You can see the mass effect on the bladder, and here's the uterus being displaced. Teratomas are also very well seen. The teratoma is the most common benign ovarian tumor, accounting for 30% of the benign ones, and accounting for a much larger percentage in premenarchal females. You look for all the signals of the various tissues of origin. Here, pregnant female who had a left adnexal mass discovered at obstetrical ultrasound. You can see here is a large teratoma. To orient you, these are T1 scans, proton density T2 scans, and T2 fat sat. Notice that we have areas that track with the fat here. That's a fat sat area. There's areas that track fluid here and here. And then other areas that track soft tissue density. After she delivered, it was resected. It was a teratoma. I'm not going to go into polycystic ovaries because this really isn't an imaging diagnosis. While there have been classic findings described, you hardly ever see them, but I'll leave that to you reading the notes. Endometrial carcinoma is something you can see with MR. It is the most common gynecologic malignancy and usually presents as postmenopausal bleeding. MR is fairly sensitive, but still not good enough for screening, with variable staging accuracies reported. What you're looking for is disruption of that dark junctional zone on T2 scans. Here's an example, T2 fat sat and a post-infusion T1 scan of an early endometrial carcinoma, early meaning it hasn't gotten beyond the uterus yet. Notice here, to orient you, this is a postmenopausal female, so the very thin myometrium is as expected. Here we have the junctional zone. Here we're starting the dark cervix, getting into the junctional zone. It doesn't show well here, but it did appear intact on the original images. As it comes down through here, you lose the junctional zone, and there was this lobulated mass in the cavity. Now, on the post-infusion scan, you can see the normal bright enhancement of the myometrium, and here you can see the lobulated enhancing tumor. Notice that there is superficial invasion of the myometrium, but it is not all the way to the serosal cervix. It involved the internal cervical os, but did not extend to the external cervical os, and pathology correlated this completely. Notice that there's more tissue here than you see here. That's because this was additional necrotic debris, and so you can actually get, in this kind of a situation, if you want to know exactly where the tumor is, that might be an application for post-infusion imaging. This is an example of a small endometrial polyp picked up incidentally during a hunt for fibroids. Here's just a small little nodule along the anterior wall of the endometrium, and here you can see on post-infusion some slight differential enhancement there, and here's the fibroid exophytic right there. Cervical carcinoma is the 6th most common cancer in women, with a peak earlier than endometrial cancer. It is the 2nd most common gynecologic malignancy in the 15 to 34-year-old crowd. It's very important to catch it early because it affects prognosis. The smaller, the better. Again, you're looking for increased T2 signal in that dark cervical donut on the MR scan, again with a good but not great staging accuracy. This is an example of a cervical cancer seen with endorectal coil imaging on T2 images sagittal through the cervix. Here you can see the normal dark signal of the cervix here, and here you can see this mass that's involving the entire cervical wall posteriorly, but still without local invasion into surrounding structures. Lastly, I'd like to go into some newer applications. Perianal Crohn's disease is extremely well imaged with MR, and it's much better tolerated by the patients than a barium enema because all they have to do is lay on the table. They don't have to roll over. They don't have to have tubes put in. They don't have to have an endorectal ultrasound probe put in. All they have to do is lay on the MR scanner. We do T1 axials through the whole pelvis, and then we do T2 fat-sat 5 millimeter interleaved images in sagittal, axial, and coronal planes. It provides great information on the anatomic relations of the fistulas for surgical planning, and it is really an easy scan to read. What you're looking for is just curvilinear tracts that are extending from the anus or rectum to wherever they decide to go. The skin, the muscles, they go up, they go down, they go all over the place. Typically, they'll go to the cutaneous surfaces of the buttocks or the perineum. They will be dark on T1 scans, they will be bright on T2 scans. And the surrounding fat will be of completely normal signal when they are chronic, and when there is acute superimposed inflammation, as one might expect, the surrounding fat becomes edematous and gets bright. You want to look carefully for fluid collections, you want to look for organ involvement, and you want to look for abscesses, of course. So here's an example of both acute and chronic fistulas of the perianal region on MR. To orient you, here's an axial scan, here's the anus, and what you can see is on this side there is a little band of dark signal here, and there's something going on here and here. It's just a little more tissue than you'd expect at this particular level. The T2 scans really give you a lot of information. Here you can see the anus. Here you can see there's a bright tract here that is the beginning of a fistula. Here you can actually see the little fistula coming out and splitting into a T, sending a tract anteriorly and one posteriorly. As you go more caudally, this tract here continues down and went all the way down to the skin surface. Notice the surrounding fat is black. This was the chronic fistulous tract. If you look on the other side, this continued down to the skin more posteriorly. All of the surrounding edematous change, and this was an acutely inflamed tract which corresponded with the physical findings. Here, another patient with Crohn's disease. You can see the perirectal inflammation from chronic disease, and here you can see how the inflammation is bright on the T2 scans. Here's another patient with a chronic fistula, just to show you how multiplanar imaging can help with your surgical planning. Here you can see the rectoanal junction, and there's a little bit of something coming out here, but the coronal scan really shows it nicely, this tract extending obliquely upward, leftward into the ischiorectal fossa. This is one of the worst fistulous networks I've ever seen of Crohn's disease. And just to show you how MR can demonstrate it, here's the T1 and the T2 scans. This is a severe, extensive chronic fistulous network. Here you can see the origin of the perianal tract. It goes posteriorly and then just starts branching everywhere throughout the entire subcutaneous gluteal fat, coming here into the right ischiorectal fossa as well. This is the same patient. Here was the sagittal. You can see how it goes posteriorly and is just branching everywhere. And this was a coronal posteriorly through the buttocks. And you can see just how extensive all these fistulous tracts were. So, like I said, it helps with the surgical planning. Here's another one where you can see an ischiorectal fossa abscess. Here was the origin of the fistula more caudally, and it went upward and leftward to form this little abscess cavity in the left ischiorectal fossa. And here you can see another chronic fistulous tract heading off toward the right side. Here another plane through it, again showing fistulous tract here. Here is a parasagittal view showing the other component of it. How long these can be, the multiplanar imaging is really helpful in determining, where these things go. Here again in the left ischiorectal fossa. And here yet another case of a young woman with Crohn's disease and developed vaginal pain, and imaging showed here a small collection in the rectovaginal septum, which turned out to be a small abscess that they drained with good relief of symptoms. And one final one showing how the MR can pick up distant abscesses, things you wouldn't find with fistulography or barium enema or ultrasound. Here, another case. Here you see the perirectal inflammation. And notice here the fistulous tract here coming here. And look at all of this out here in the right gluteal musculature. Here's another normal prostate, by the way. And here you can see just more extensive involvement. Here you can see it going into the iliacus muscle. Here it's going out laterally into the gluteus musculature as well. This thing was kind of flipping over the iliac crest and involving both sides of that hip. Here you can see the network originating here laterally around the femur, and here you can see on the coronal just how long and extensive this hip abscess was, all from Crohn's disease. So that is an overview of pelvic imaging.
Spleen is sort of an area near and dear to me, and I guess it belongs in the purview of abdominal imaging. And a lot of people feel very uncomfortable with differential diagnoses in the spleen. I think the next half hour will be, I hope to give you all you need so you feel comfortable looking at lesions in the spleen. First, let's talk a little bit about normal variation, anomalies and congenital disorders. It's very common to see normal variations in shape and contour of the spleen. Accessory spleens are common. The other abnormalities, congenital abnormalities, are uncommon or rare or hard to see radiologically. Splenic band. Asplenia, polysplenia will be covered primarily in the pediatric portion of the course, although I'll show you an example of polysplenia. Wandering spleen can present both in children or in adults, and splenogonadal fusion is very rare. This is just a sagittal image just to remind us about the normal variation in the lobulation and contour of the spleen. Something that you don't necessarily appreciate on axial images. You realize the lobulation of what's called the medial pole of the spleen, but sometimes I've seen lobulation on the superior aspect of the spleen like this. Or sometimes you see little things that you want to call accessory spleens, but they're not because they're actually connected to the main body of the spleen, so they're a splenic bud. To be actually an accessory spleen, it has to be a separate entity, usually has its own separate blood supply. This would be an example of accessory spleen. If you look at all the images, you can actually trace this little wandering vessel and see the separate supply to the accessory spleen. I think it's important to recognize normal variations, particularly simple things like clefts in the spleen. If you're not used to looking at it, particularly residents on call, looking at a trauma case, first year on call, all of a sudden all these things had a common normal variance, start wondering whether they actually represent splenic fractures. So just keep it in mind, it could be confusing in trauma cases. And I think most people, if I ask you to raise your hand, how many people have seen accessory spleens on CT, almost everybody raises their hand. And I ask you how many people have seen accessory spleens on ultrasound, and nobody raises their hand. Well, that obviously can't be true. You're probably just seeing it, not recognizing it. And the way you recognize that something is accessory spleen, whether it's ultrasound, CT, or MR, is it has the same enhancement or texture characteristics as the main body of the spleen. And that's basically it. So it'll look like splenic tissue in terms of its texture and enhancement characteristic. This patient has had a splenectomy. Oh, but there's something over there that looks like spleen. So what is it? Well, that's hypertrophy of an accessory spleen. So in patients who've had splenectomy, small unrecognized accessory spleens might then hypertrophy. Now, the patient may have had a splenectomy for various disease processes or post-traumatic, for example. It doesn't really matter. Will the hypertrophy of accessory spleen confer immunologic competence? Probably not. It's been studied a little bit. Same thing with an entity that I'm not going to show you called splenosis, where you have multiple little implants of splenic tissue growing in patients who've had a ruptured spleen. They may take up sulfocolloid. They may take up various agents on dedicated tagged red cell studies, yet they actually do not do a very good job at conferring immune competence. What about this one? You do a scan, the spleen belongs up here and it's not there. Where is the spleen? So keep scanning, and sure enough, the spleen is way down in the pelvis. And this is a wandering spleen. Now, a wandering spleen means the spleen has a long pedicle. Like the liver, the spleen is really an intraperitoneal organ, but it has a very short pedicle, and some people maybe correctly or incorrectly think of it as retroperitoneal. It's truly an intraperitoneal organ with a short pedicle, but if that pedicle is long, just like you can have a very mobile right colon, you can also have a very mobile spleen. Now, patients with a wandering spleen may be symptomatic, and when they are, they usually present in childhood, but patients can go on with wandering spleen asymptomatic as an incidental finding in adulthood, as this patient is, or become symptomatic. Why would they become symptomatic? Well, that long pedicle allows the spleen to have mobility not just in an cephalocaudal direction, but it may twist and essentially torse. As you get torsion of a wandering spleen, that spleen will infarct, and you'll have global infarction of the spleen and no enhancement. What about this case? Here's a sulfocolloid scan. Here's the liver, and here's the spleen. Well, the spleen belongs in the left upper quadrant, and it's way down in the pelvis, so you think maybe it's a wandering spleen. And, of course, I'm talking about wandering spleen. But it has a big hole in it, big filling defect. So what's that diagnosis? A lot of people will look at that and incorrectly say, oh, it's a wandering spleen with torsion and infarction. No, it can't be, because when you get torsion of a wandering spleen, it pinches off the splenic artery and the vein, and you always get a global infarction of the entire spleen. That can't be happening here because you're seeing uptake in the spleen. So this is a claw sign. This means there has to be a focal space occupying mass in the spleen. This is a cyst, a congenital cyst. So two congenital abnormalities in the same patient, a wandering spleen and a congenital cyst. It's just a coronal MR just to show you multiple right-sided spleens in a patient with polysplenia. Again, that will be discussed in more detail in the pediatric portion of the course. But here in this ultrasound, you can also see that you're in the right upper quadrant, and next to the kidney, there's a texture of spleen with multiple foci, and again, this is a patient with polysplenia demonstrated by ultrasound. So patients with polysplenia have various syndromes, various abnormalities, particularly bilateral left-sidedness. They may have situs ambiguous with left isomerism, bilateral left lung, IVC with intrahepatic interruption, various cardiac abnormalities, including an ASD, VSD, and various associated abnormalities. Now, a dense or an opacified spleen is something that you might see on CT, and the pattern is different for different things. And I broke it down into multifocal, rim-like, and diffuse. If you have multifocal areas of high density, usually dealing with everyday granulomata due to granulomatous disease such as TB, histo, or less commonly brucellosis. You also can have calcification in tumors, and various infections, particularly pneumocystis carinii, can give calcific foci, and abscesses can heal with calcification. Usually, if you see rim-like calcification, you'll be dealing with a cyst, be it a congenital or acquired, rarely parasitic, or a healed abscess or residua of a healed hematoma. And sometimes on the surface or capsule of the spleen, you'll see calcification in patients who've previously had peritonitis or sometimes subcapsular bleeds. High density on the non-infused CT can also, if it's diffuse rather than focal, can be seen with hemochromatosis, infarction due to sickle cell disease, and some rare entities that are case reports in the literature, such as lymphangiogram contrast or old cases of thorotrast. Everybody's seen granulomata in the spleen, but maybe you don't remember seeing one on ultrasound that this profound, but just multiple foci, many with shadowing throughout the spleen, and this should be granulomatous disease, TB, or histo, or brucellosis, which is what it is. This is an old case actually reported by Arnie Friedman, and a patient with thorotrast exposure, and you could see a very thin lace-like pattern. It's actually hard to make out the lace-like pattern, but you could show the general increase in density over the liver, the general increase in density over the spleen, and then you could see these very, very dense little foci representing nodes in the peripancreatic distribution with some lines representing lymphatics. So patients who got thorotrast, and this was administered in the 1920s, 30s, 40s, and actually if you look at the literature as late as the early 50s, so there was still, until recently, some people walking around who actually had this. The thorotrast was taken up by the reticuloendothelial system of the liver and the spleen, and the drainage of the thoratralis was therefore into the peripancreatic nodes. And the thoratralis is an alpha emitter, and these patients would then get radiation damage, and therefore the lymphatics would sclerose off, and that's why the density is limited to the liver, spleen, and peripancreatic nodes. Unfortunately, due to the radiation damage, they would also get malignancies such as hemangiosarcomas, cholangiocarcinomas, hepatocellular carcinomas. And here you can actually see that the modeled pattern of the spleen is interrupted on the plain film enough that you could suggest that there's actually a space-occupying mass, which was a malignant vascular tumor in the spleen. This is a case courtesy of Randy Radden that was subsequently published. And this is a patient with pneumocystis carinii involvement. I believe the patient had AIDS. And with pneumocystis carinii, there can be multiple organ involvement. There's nodal involvement, in this case, foci of calcification in the liver and the adrenal gland. But the spleen, this is the most profound example I've seen of splenic calcification, and it's the only entity I've seen give this unusual, bizarre, dense pattern of linear, thick structures crisscrossing the spleen, pneumocystis carinii. As opposed to a case like this, where the spleen is small, is heterogeneously dense but calcified. And this is autoinfarction in a patient who has sickle cell disease. And sometimes we go read these cases in sickle cell disease and nobody notices that the spleen is missing because it's actually so thin and rim-like that it's confused on a quick read for a rib. And you just see it really plastered up very, very high, and almost your eye just catches it as though maybe it's a rib. But the advanced sicklers will have this autoinfarcted spleen that may ultimately calcify. So depending on the stage of disease in sickle, you may find splenomegaly, or you may find a normal-sized spleen, or you may find a small spleen with autoinfarction. When they get small, they commonly calcify. As opposed to a patient like this who's also a sickler with an autoinfarcted spleen, but the spleen is not big, not small, but very, very densely calcified with some little islands of sparing, and that can occur as well. What about a scallop contour to the spleen? Let's speak about it from a differential perspective. Things that might scallop the spleen would be infarcts, hematoma, metastatic implants, possibly even pancreatic disease. It's a patient with trauma, a laceration in the spleen that has a typical sawtooth pattern. You want to look for any perisplenic hematoma or subcapsular hematoma, rib fractures as a clue, and obviously the history is quite helpful. Here's a patient with also a hematoma, multiple hematomas, subcapsular. When it's subcapsular, it exerts pressure and therefore scallops the spleen, as opposed to when the capsule is ruptured and you get perisplenic bleed, but the pressure is relieved and then the contour of the spleen is not as likely to be scalloped. And again, the history and associated findings are going to be helpful, as opposed to a case like this where the patient has a known GYN malignancy. In this case, it's actually an ovarian carcinoma. There's metastatic disease diffusely, both hematogenous and intraperitoneal spread. And as you know, gynae malignancies, particularly ovarian carcinoma, spreads by way of normal pathways of intraperitoneal spread up and down the left paracolic gutter in a pattern similar to that you would find, for example, in peritoneal infection and abscess spread. And so you can get implants on the surface of the liver, the spleen, or the undersurface of the diaphragm. In this case, we have soft tissue tumor on the surface of the spleen, scalloping the contour of the spleen. That's metastatic ovarian carcinoma. Splenic infarction is not terribly uncommon. Let's talk about that a little bit. You'll definitely see examples of that. Now, the etiology of splenic infarction is usually occlusion of end vessels, embolic phenomena, but it can be due to compression or thrombosis of the splenic artery and or vein. Experimentally, actually, it's very uncommon to find infarction just due to clamping off the main splenic artery. There's a lot of collateral flow. You actually need end vessel occlusion in various experiments that have been done a long time ago in animal models in the early days of CT, or a combination of arterial and venous occlusion. So embolic phenomena, pancreatic disease, torsion, etc., can give infarctions, sepsis, any cause of splenomegaly. So anytime you see a big spleen due to infiltrative disease or any of the host of diseases that give moderate or marked splenomegaly, it's not uncommon to see foci of hypodensity that actually are infarction on cut path specimens. Now, differentiate between acute and chronic infarction. The natural history of a splenic infarct, again studied in these older experiments, is one of healing. Actually, the vast majority of splenic infarcts are small, they're actually round or irregular, and they heal completely. So the classic wedge-shaped hypodensity is typical for the vascular distribution in any solid organ. So whenever you see a wedge-shaped abnormality in a solid organ, you think infarction. But I just want you to remember a few things. One is, if it's not wedge-shaped, infarct is still in the differential, and in fact, in the case of the spleen, as we'll see, is likely. And secondly, if you have a patient with an acute infarction, if they have some disease process that might predispose to infarction, if they develop acute left upper quadrant pain, you may get referred to some sort of imaging, CT or ultrasound, to evaluate for an acute infarct. Let me use this to mention that any disease that involves the spleen can irritate the left leaf of the diaphragm. If the spleen gets big due to splenomegaly, due to a mass, it will irritate the left leaf of the diaphragm. That can cause pain referred to the left shoulder. That's called Kerr's sign, K-E-H-R'-S, Kerr's sign. So if a patient has an acute infarct, then you might want to look for various complications. Let's take a look at some examples. Here's an incidental hypodensity in CT. It's obvious in the axial plane that it's wedge-shaped. That should be an infarct. Okay, that's sort of an Aunt Minnie. That should be an infarct. And they may stay there forever, or they may heal. Most heal, but when you see it and it's wedge-shaped, it's an infarct. They can be multifocal. This patient has myeloproliferative disorders, multiple wedge-shaped foci. These are also infarcts. There are two other interesting patterns with splenic infarction that are much less common. One is this, where I've seen a more geographic, unusual pattern. And for those of you, I don't know if we had it in the lectures this morning on liver, but in discussing diffuse liver disease, one of the patterns of infarction are also something like this. It could be very unusual, peribiliary or geographic. I'm not sure the pathophysiology of this, but it's definitely been documented. So this is a less common pattern of infarction. And a third less common pattern, but a very interesting one, again, seen in sicklers, is a sequestration crisis. In patients with sickle cell and sequestration, you will get these peripheral infarcts with almost like a hair on end kind of appearance, and general other causes of infarction don't give that appearance. That's a fairly typical appearance for splenic sequestration. And there's a patient with splenic sequestration, patients in acute pain, they're a known sickler. And I granted on any one image there's no way to show this, but if you sort of get used to the particular Doppler gain settings that you use, or if you use power Doppler, you'd see a lot more peripheral flow in the spleen, and only the central vessels are lighting up at this particular gain setting. So cold on scintigraphy, wedge-shaped. It generally has a natural history from being poorly demarcated to sharply demarcated and then healing again, being hypointense. I don't have any examples of a documented infarct with gas, but you certainly can have gas in an infarct even without infection. Let me just mention the sign of impending rupture. There are case reports in the literature of acute infarcts with splenic rupture. If you ever get referred a case, most of us are interested in this only because we see it as incidental findings in cross-sectional imaging. But every once in a while, if you do have a patient who has acute left upper quadrant pain and is referred to you for possible splenic infarction, the one thing you do want to remember is there are cases of death due to splenic rupture secondary to an acute infarct. Almost any entity that involves the spleen, you'll find a case report of splenic rupture. So the first thing to know is, well, that's uncommon. But if you're going to think about the possibility, the only thing I could tell you is there are some papers in the literature that suggest that you should do daily ultrasounds if there's an acute evolving infarct. Because if you see that the patient on the day before had no abnormality, and then all of a sudden you see some subcapsular or pericapsular fluid, that would suggest that there's a tear in the capsule and that patient might be predisposed to a dramatic rupture and an event that would cause death. Okay, enough for infarcts. Let's talk about abscesses. Abscesses are usually multiple because they're spread hematogenously and in fact usually involve multiple organs. Particularly when the spleen's involved, you'll usually see liver involvement. About 25% can be due to other mechanisms of involvement that's much less common, all usually very unusual, direct spread due to contiguous involvement and things like that. Superinfection of a hematoma. Complications are rare, such as fistula formation, rupture. Old literature gives a high mortality. I really didn't check recently, but certainly the mortality is much lower now because of recognition, early antibiotic and interventional therapy or surgery when necessary. As an example of a salmonella abscess, I believe, that ruptured, and here's the past specimen. I think the patient, this spleen actually ruptured during surgery. So splenic abscesses almost always have an abnormal plain film, but it's almost always nonspecific and not terribly helpful. It basically depends on the maturity and size of the abscess. It could be small or it could be huge. Patient may often has something such as an associated pleural effusion, atelectasis, or a left lower lobe infiltrate, maybe an abnormal gas collection if you get lucky, or an air fluid level. Ileus on splenomegaly if the abscess is big. And on cross-sectional imaging, it basically depends on, is this one abscess and what size? They're usually focal, can be multifocal. It can look like a simple cyst, or if it has a lot of debris in it, it'll look like a mass. I think the key here is the clinical. Look, if you have a splenic abscess, you're sick. So these patients are routinely ill. You got fever, white count, chills. It may be an immunocompromised patient, but not always. So while you might think that a hypodensity in the spleen is a very nonspecific finding, when you take it together with the clinical findings, it actually becomes a fairly specific finding. I'll emphasize that again, and that really is my take-home message as we continue through the lecture. Think about the cross-sectional imaging findings and the clinical findings. So on CT, it may be hypodense, may or may not have fluid or gas density, and rarely might be associated with portal venous gas. So here's a hypodensity in the spleen. Notice the very sawtooth pattern of this documented and proven abscess, because at path, what happens is near the abscess, you get focal areas of infarction. So that accounts for these little wedge-shaped areas. And actually, you might hear people say that, well, the capsule of the spleen is a barrier to the extension of infection or tumor. That's not really true. Here's infection breaking through the capsule to involve tail of the pancreas as well. And this spleen at path, I'm not going to show you the path, it was basically, it sort of looked like silly putty. It was just a blob of not recognizable spleen with mush debris inside. And this was an unusual organism. It turned out to be an actinomycosis abscess. So there's no recognizable normal spleen. This is the same case, actually, on ultrasound. A lot of internal echoes due to the debris within the abscess and the thick septation or residual piece of spleen inside. This is another patient with an abscess. And notice the little dot dash pattern of gas on the periphery of this abscess and the little air fluid level on the non-dependent portion. And that may be associated with gas-producing organisms, but is actually reported, as with splenic infarction, you can have abscess of non-gas-producing organisms and see gas in the abscess as well. This is a patient who was an IV drug abuser with staphylococcal abscesses. There's multiple abscesses in one area that's certainly an infarct with a typical wedge shape. One special case that deserves attention is the concept of microabscesses, or small little dots studding the spleen. These are often immunocompromised patients. Now, the use of the term microabscesses in the literature is not as strict as in our general parlance and jargon, where we usually think of microabscesses as salt and pepper, very tiny little things. But anything even 1-2 centimeters can still be called microabscesses. The differential primarily is in Candida, Pneumocystis carinii, Mycobacterium avium complex, and Bartonella sinensis or Rochelemia. It's the same organism. Two other entities that can give a similar pattern but are clinically obvious are Gaucher's disease and sarcoidosis. The natural history is one of inflammation followed by fibrosis and calcification. Here's a typical cut gross section to burn into your memory as a classic example of candidal microabscesses. It's a little old case, but it's a nice one that I had, and that is liver and splenic involvement, but the abscesses in the spleen are a little more confluent and conspicuous. And here's a typical microabscess pattern. Here's a little more confluent, larger abscesses in the spleen. And some of the older literature described there are various patterns, including one called a wheel within a wheel pattern, which is sort of like a target appearance where the central dot is the candida, and around it you have a little inflammation, and around it you have fibrosis. In fact, looking for that, even having several cases of candida, it's hard to find that particular example. More common just as a bullseye appearance or a nonspecific hypoechoic multifocal hypoechoic lesions. And when they calcify, then you may see some shadowing on ultrasound and may be hyperdense on non-infused CT. Splenic cysts. Well, let's talk about that a bit, since that's probably one of the most common entities you're going to come across. I think it really is of academic interest only, really, to differentiate the kinds of cysts. Cyst in the spleen, unless it's going to rupture or is causing symptoms, it's really also a leave-me-alone lesion. Parasitic cysts, which are very important, are common outside the U.S., but in North America, parasitic cysts in the spleen are horrendously rare. So if you see what looks like a cyst in the spleen, as an incidental finding, the patient has no known malignancy, no lymphoma, no signs of infection, you're probably dealing with a cyst, and it may be due to previous recognized or unrecognized trauma, in which case it's actually a false cyst or mesothelial or post-traumatic cyst. Any of those terms are acceptable. And that's thought to represent the majority of splenic cysts. And the minority are thought to be congenital, also called by the pathologist true cysts or epidermoid cysts. They tend to be big and provide palpable masses, usually solitary, but not always. Classically, a very large unilocular lesion with a trabecular lining. And, anybody who has a cyst can get traumatized. You can get kicked or run around and play ball, so you can get bleeding into a cyst. So even if you open up a cyst and see blood in it, doesn't mean it's a post-traumatic cyst. The only way you could really tell is by looking at it histologically. So grossly, tend to be very, very large lesions, have this trabeculated lining of fibrous tissue. Parenthetically, you might note this acute angle here. So when you have a big mass in the spleen, sometimes one pole of the spleen is spared and produces an acute angle. Splenomegaly never does that. If you ever see that on a plain film, you could tell that there's a mass in the spleen and not splenomegaly. The only way to tell a true cyst is it has an epithelial multilaminated lining, whereas the false cyst has this nonspecific mesothelial lining. So on ultrasound, they generally look like cysts unless they bled. And if they bled, then you can have trouble telling it from a complex mass. An organizing hematoma can produce a very confusing picture. And on CT, likewise, 9 to 25% of them, particularly the post-traumatic ones, may have calcification. So here's an old nucleus study showing that it can be multiple. Here's a plain film showing you that relatively acute angle right here. Can you make that out? I'm going to follow the border of the spleen. That's not splenomegaly. Splenomegaly doesn't give those relatively sharp angles. That's a big cyst in the spleen. Here's one with an unusual one with a lot of calcification in the trabeculae and the septations. Here's another one incidentally picked up on an old IVP. You get sort of the bodygram effect. And you see one here, the inferior pole of the spleen. And here's a big one on an angiogram just showing how the spleen has a short pedicle, and therefore marked splenomegaly or lesions in the spleen are intimately related to the retroperitoneal structures and will deviate the kidney and the aorta. An old ultrasound showing, I call it the missing link in anthropology. We see a lot of trauma, but you don't see a lot of pseudocysts, and this is sort of trauma on the way to the pseudocyst. This was in the AFAP files of post-traumatic pseudocysts. There's organizing rings and solid components of organizing hematoma. And this is a similar case where you have multiple lesions, some with calcification. The dominant lesion has ring-like calcification and heterogeneous round areas of high density within, representing organizing hematoma. Splenic hemangioma is the most common benign tumor of the spleen, has various types. Calcification can occur, but is rare. A lot of what you know about hepatic hemangioma is true of splenic hemangioma, but the typical pattern of rim enhancement is much less common. These are usually cavernous hemangiomas with an endothelial lining containing blood-filled spaces, and they could have two gross morphologic types, some with a very large blood-filled spaces and some what they call the spongy type with a lot of small blood-filled spaces. So here's one on ultrasound, a well-demarcated echogenic lesion, similar to what you might see in the liver. Here's multifocal ones in a patient with Kipple-Trenani-Weber syndrome and multiple hemangiomas in the spleen. Here's a large lesion that actually has cystic and solid components. Hard to recognize that it's one large lesion, but it was on path. As was this one, which is the more solid type, but has a lot of blood in it, so you see a lot of through transmission. These are all hemangiomas, and here's another one. Sort of fills in on delayed images. Here's an MR showing that on T2-weighted images, just like in the liver, these are hyper-intense. And here's one that bled. Here's a lesion in the anterior pole of the spleen, calcification. Okay, let's use this as an unknown. Somebody shows you this. Patient has no known primary, no lymphoma. Even if there's no recognized trauma, the fact that there's two lesions, so two foci of abnormality separated by normal pulp, and there's a focus of calcification makes hemangioma more likely. Hemangioma is the most common incidental finding tumor in the spleen. And this elderly man actually came back 2 weeks later with acute right upper quadrant pain, so you were able to figure out by comparing with the previous lesion that his hemangioma ruptured, and he was taken to surgery emergently, successfully. Lymph angioma is very uncommon, so I'm not going to show you any examples, extensive examples of that, but it can be solitary or part of a syndrome. And I want to just finish up by talking about the last two entities, which is splenic lymphoma and metastatic disease, and a few quasi-unknowns. Okay, that's the lymph angioma. Sorry, I do have a lymph angioma to show you from a gross specimen, again from the AFIP files. Very similar micro to hemangioma, except it's filled with eosinophilic staining lymph fluid instead of blood. And here's actually an old ultrasound with a documented lymph angioma. And here's a CT from the Naval Hospital when I used to be in Washington, D.C., multifocal lesions that also was a proven lymph angioma. The take-home message on splenic lymphoma, which you all have seen, is that lymphomatous involvement of the spleen is usually stage 4 disease. That means it's usually multi-organ involvement. Solitary splenic lymphoma is rare. We wrote a paper about it from the FIP, and it can take a variety of patterns: splenomegaly, which is not reliable, infiltrative pattern, small miliary masses, large masses, a single large solitary mass which might become cystic. I'll show you some gross example. Extensive involvement, multifocal masses in the spleen, and on CT, these lesions can be ill-defined, multiple lesions enlarging the spleen, and they're going to definitely be more obvious on infusion. This is an example, I've had just a few of these, that mimics the microabscess pattern I showed you for candidiasis. So this is a normal-sized spleen with lymphomatous involvement that has just a very sandy texture with multiple small punctate hypodensities. Here's a single larger lesion with some central necrosis, and another lesion that for all the world you might think is a cyst, but when you look at it on delayed images, you can see that there's actually mural nodularity. And this patient has a known lymphoma. This is also splenic lymphoma. Here on ultrasound, multifocal lesions in the spleen growing out of the splenic hilus towards the stomach. Here on CT, actually wrapping around the stomach, so it's really multifocal involvement rather than contiguous spread. And then the lesion becomes necrotic. This is a very necrotic lymphoma on ultrasound. That's the CT that goes with the same case, fluid density. And this is a rare complication with actual fistulization due to lymphomatous involvement to the stomach, where the oral contrast from the stomach is actually getting through a fistula into the spleen. This is the same case that went to angiography, and you see a blush due to bleeding due to that involvement. And here's a patient with lymphoma complicated by splenic vein thrombosis, a late phase from an angiogram showing extensive collaterals secondary to the splenic vein thrombosis. I showed you I had no examples of gas due to infarction without infection. This is a lymphoma with necrosis, but it got superinfected with candida. And there's gas and fluid in the spleen. And then the last ones are unusual cases. If I showed you this as an unknown, you probably would say trauma with a subcapsular hematoma, but there's been no trauma. There's a patient with pancreatitis, and this is dissection of pancreatic fluid with essentially subcapsular pseudocyst, and this is the same diagnosis, but not subcapsular, rather intraparenchymal, because the wall here is thick, not thin, and known pancreatitis. And just a final word about metastases. When you have splenic involvement, you almost always have liver involvement. So look, common ones that do it are melanoma, lung, breast, prostate, colon, stomach, and ovary. Here's an implant, metastatic, with a fluid level on the surface of the spleen. So I conclude by sort of putting it together with the clinical, is that clinical helps you. Fever, think about an abscess, necrotic tumor. Weight loss, known primary, think about METs. Adenopathy, METs or lymphoma. Trauma, hematoma. Travel history, immunocompromised patients. You think about infection. We went over patterns of calcification as opposed to incidentalomas where there's no known primary. And then think about hemangioma, cysts, a less likely METs or a primary. And certain known disease and patterns like sickle cell, Gaucher's, pancreatitis. And rare splenic rupture, think about hemangioma, infarct, and abscess. Those are my take-home points for cystic lesions, microabscess pattern. We went through that differential. I think CT is very good in general for most differential diagnostic possibilities. Ultrasound, nucleus scintigraphy still has a role, as does MR. Thank you very much for your attention.
We're going to go through normal anatomy, cover abnormalities of the cortex, then the medulla, and go to miscellaneous abnormalities after that. The normal anatomy is an alphabet soup for the adrenal glands, with probably the Y shape more commonly seen. The thing to remember, though, that is no matter what the shape, each limb should be less than 1 centimeter thick and less than 4 centimeter length. Anatomic relations are important when looking for the glands. For the right adrenal gland, it should be posterior to the IVC. Here's the gland, here's the IVC, medial to the liver, lateral to the crus, anterior and superior to the right kidney. For the left gland, you're looking for it to lie lateral to the aorta and the crus, anterior and supermedial to the kidney, behind the pancreatic tail, and a little caudal relative to the contralateral gland. So to get into some pathology, the non-functioning benign adenomas are typically discovered incidentally. They are seen in up to 8% of autopsies. Carcinomas are more likely to be hemorrhagic or necrotic. And in general, the adenomas are a little more common in elderly obese diabetics, elderly women, hypertensives. There is an increased incidence of adenomas in malignant tumors of the bladder, the kidney, and the endometrium. Imaging is usually done with CT when you're trying to characterize one of these because it can resolve a mass as small as 5 millimeter. The accuracy for an adenoma is near 100%, and for an aldosteronoma, 70%. It's more common to use MR to characterize a mass previously identified or something that's atypical. While ultrasound is useful in children, it isn't very useful in adults unless the mass is large. And then right after I tell you that, I show you an ultrasound exam of an adenoma. The majority are between 1 and 6 centimeter, most less than 3. They can be bilateral and appear as well-defined, rounded, homogeneous masses. On CT scan, their low attenuation pre-infusion is due to their high lipid content. Calcification is very uncommon in these, as is central necrosis or hemorrhage. So when you use non-infused CT scan, the sensitivity and specificity of your characterization of adenomas will depend on the Hounsfield unit level you select as your threshold. We will typically use 10 Hounsfield units at our institution because it's a reasonable compromise between the two. If the density measurement is over 20 Hounsfield units, it's unlikely that there's a significant fatty component and it's likely malignant. But in cases where malignancy just doesn't seem to fit the picture, we will do an MR. On MR, these things will be a little dark on T1, a little bright on T2, but the best test is the in-phase and out-of-phase gradient echo imaging. This is the most sensitive test for detecting microscopic fat. It's also been called phase shift for imaging. And what you are looking for is homogeneous signal loss throughout the gland, indicative of a microscopic fatty component. And here's an example. T1 fat sat, T2 scans, notice just kind of nonspecific signal characteristic of the lesion. When you do the in-phase, out-of-phase imaging, here's in-phase, here's out-of-phase, notice the homogeneous, diffuse loss of signal throughout the entire nodule. If there is not a significant fatty component, then you will only have signal loss at the margins where you have the soft tissue fat interface at the edges of the gland. The adrenal spleen ratio has been described by McNichols et al., and the reference is, I think it's in your handout. If not, contact me and I can give it to you. But basically, they found a way to quantitate the adrenal signal loss as it relates to the internal standard of the spleen. And this is essentially if there is if the adrenal spleen ratio is less than 70, this is indicative of a 70% loss of signal, and it's a benign lesion, no further workup required. If it's over 80, it's malignant, you can biopsy it, and if it's in between, it's indeterminate, and you decide clinically whether or not you should biopsy now or watch it. So to go into some clinical syndromes, the adrenal cortex can have several overproduction syndromes when you have pathology involving the cortex. These include Cushing syndrome, Conn syndrome, the adrenal genital syndromes, virilization, feminization from tumors that produce the sex hormones. And Cushing syndrome is the result of excess glucocorticoid secretion. It can be from endogenous sources, which is overproduction of cortisol by the adrenal gland, most commonly from hyperplasia of the gland related to excessive ACTH production in the body. 20% from adenomas, 10% from carcinomas. It can also be exogenous from, example, steroid therapy. Cushing disease, as opposed to Cushing syndrome, is very specifically bilateral adrenal hyperplasia that's due to ACTH overproduction from a pituitary adenoma. That is a differentiation from Cushing's syndrome, which is a big garbage can of cases of overproduction, and in this particular case, from a specific etiology. So what do you see in hyperplasia, which would be one of the findings in, to go back, whether you have hyperplasia versus adenoma. So looking into hyperplasia, you get bilateral symmetric enlargement of both glands. It's not unilateral, it's bilateral, it's symmetric. The normal configuration of the gland has to be preserved to call hyperplasia. The density will be homogeneous on CT, and it'll show some signal loss on out-of-phase scans. And here's an example of adrenal hyperplasia. Notice here we have just a fat gland preserving the contour. And I don't have a contralateral gland to show you because it was resected, because they both looked alike. They resected one. It was proven pathologically to be hyperplasia. So it's sort of path-proof without all the findings for you. Here's another example of adrenal hyperplasia by MR. Notice here you can see not as well resolved on the in-phase scan, but here you can see on the out-of-phase scan you still have the V-shape in this example preserved with just uniformly thickened limbs. This was another one where the contralateral gland had been already hacked out. You can have other ACTH-secreting tumors that can cause Cushing's syndrome, including oat cell carcinoma, bronchial carcinoid adenoma, pheochromocytoma, and miscellaneous other tumors. Macronodular hyperplasia is yet another cause of Cushing's syndrome, where you get nodular enlargement of the gland. The nodules tend to be less than 3 centimeters, and they are commonly due to pituitary adenomas. Here's an example of macronodular hyperplasia where you can see that there are numerous individual nodules throughout this gland and very lumpy, bumpy look to them, and that was macronodular hyperplasia. Primary pigmented nodular adrenocortical disease has been described in children, young adults, where it is cortisol production by pigmented nodules of the hyperplastic cells. It's treated with bilateral adrenalectomy and steroid replacement. Conn syndrome, or primary aldosteronism, is a rare cause of hypertension. You will also see hypokalemia, decreased plasma renin activity, increased plasma aldosterone after sodium loading. The vast majority of these are due to benign adrenal adenomas and are treated surgically. If they're due to hyperplasia, you're managed medically, and very rarely they're due to carcinoma, imaging findings as we've just described. The adrenal genital syndromes are incredibly rare. They're due to inborn errors in the adrenal enzyme system, with each enzyme deficiency producing a different form of congenital adrenal hyperplasia. They all show a hyperplasia pattern. You can have androgen-producing tumors that will result in virilization. They can be benign or malignant tumors of the adrenal cortex, and they can present at any age, though if it's from a malignancy, they'll tend to present later than if it's congenital. Feminizing tumors are very rare, typically in men, but though they have been reported in women, these will present with gynecomastia. Now, how about primary adrenal cortical carcinoma? Since we've mentioned that some of these preceding tumors can be benign or malignant, what do the carcinomas do? They are uncommon. There's 1 in a million incidents of it. Men and women affected equally with a median age of the 5th decade. They more commonly present in the left gland, though up to 10% can be bilateral. Half are non-functional, and those may present simply with abdominal pain or a palpable mass. On CT, you look for a large tumor, often 4 centimeters or greater at presentation, with central necrosis and irregular enhancement. Clinically, you can look for signs of functioning tumors of the various syndromes that I've just described. They will calcify in up to 30% and can be locally invasive or metastatic at presentation, frequently involving the liver and lymph nodes. You can have tumor invasion of the renal vein and IVC, and by MR they will be heterogeneous on T1 scans with kind of slightly brighter T2 appearances. Here's an example of a patient who presented with Cushing disease from an adrenal carcinoma, and here you just see kind of a slightly irregular, slightly heterogeneous mass, a little calcification here. Note the marked fatty infiltration of the liver associated with Cushing's disease. Here's another one with an adrenal carcinoma. On the other side here is a more ill-defined, somewhat lobulated mass, and here you can see that it is invading the adrenal vein and getting close to invading the IVC. Again, carcinoma on MR, you're looking for heterogeneous signal on T1 and slightly bright T2 signal. You're not going to see the calcifications the way you see them on CT scan. And here's an example of an adrenal carcinoma in a 19-year-old male. The top row is the T1 scans. Note a few foci of hemorrhage there. And here are the T2 scans, very heterogeneous, large mass. Here's a coronal showing it's clearly separate from the kidney. The kidney was displaced caudally and malrotated by this mass. And here you can see on the post-infusion sequences the very heterogeneous enhancement of the mass. And here's going medially, you can see the vasculature, and here's another example of an adrenal carcinoma on that side, and I'll show you the vascular invasion that can be seen with these tumors. Again, very heterogeneous on the T1 scans, numerous foci of hemorrhage there. These are all T1 images. Here's the vasculature. Here you can see it on T2 scans, again, clearly separate from the kidney if reviewing the images as a whole. Here you can see some extension toward the IVC. And here the post-infusion scan, really helpful in showing the tumor extension towards the IVC here. This was actually, there was never a slice where you could get it off that IVC, and it was growing into the IVC as seen at surgery. You can get primary adrenal insufficiency, which will result in Addison disease, but this occurs only after you've lost 90% of the cortex. It can be idiopathic, which is the most common cause in the United States, probably an autoimmune disease, as in our former President Kennedy, I believe, had this. ACTH deficiency from the pituitary, and what you see in this case is bilateral small glands, no calcifications. Now, other causes of Addison's disease can be granulomatous involvement, TB, histoblastomycosis, which is the second most common cause. Here you're going to get enlarged glands with a normal configuration, a hyperplasia scenario, and calcifications are very common and can be very dense. You may see areas of caseating necrosis in the TB, and there's a variety of other etiologies. So that gets rid of all of our cortical problems. Now let's move to the medulla. And here we're talking about pheochromocytoma, which arises from chromaffin cells of the sympathetic nervous system. 90% of pheochromocytomas will be in the adrenal glands, though you can have sporadic extraadrenal tumors in up to 25%. It's associated with MEN2, and in this case it'll be multicentric and often bilateral. Now, up to 10% of pheochromocytomas can be extraadrenal, and that's important to remember. Then, in that case, they're called paragangliomas. They can be paracaval, para-aortic along the sympathetic ganglia, near the organ of Zuckerkandl, 1% in the mediastinum, and 1% on the wall of the urinary bladder, in which case MR is very helpful. And at this point, I want to ask, what is the organ of Zuckerkandl? I never knew what it was as a resident, so I figured it was good to throw it in. It's a para-aortic chromaffin body that is adjacent to the abdominal sympathetic plexus, seen at the bifurcation of the aorta or at the IMA origin, and it is the most common extraadrenal site of pheochromocytoma. So let's get back to the adrenal glands. Pheochromocytomas can be malignant in about 10%, but they're more often malignant when they are not in the adrenal gland itself. Clinical scenarios you've heard all about: the paroxysmal or sustained hypertension, the elevated urinary catecholamines, the VMA, the metanephrine levels. And in the familial pheochromocytomas, they don't have any association with other endocrine tumors, and they tend to be bilateral in 10%. Pheochromocytomas can be associated with several of the MEN syndromes, with neurofibromatosis, and with von Hippel-Lindau disease. CT is usually the first imaging done. It can detect about 95% of these when they're in the adrenal glands, and it also surveys the rest of the retroperitoneum. Most of these tumors will be over 3 centimeter presentation, and what you're looking for is a homogeneous soft tissue mass, though when they get larger, they will develop central necrosis. Here's a very typical looking pheochromocytoma. This one is benign, well-defined, good homogeneous enhancement, a little bit of a central scar there. And notice how by the early equilibrium phase, it's washing out. This brings to mind something that has been described in adrenal adenomas, and the Adrenal adenomas, while they can be very hypodense pre-infusion, they will show intense enhancement. They tend to wash out very briskly. In other words, if you put a density cursor on the adrenal gland and if you kept scanning further and further out, the contrast classically is described as fading very quickly. However, this pheochromocytoma has an identical washout curve in this particular case, which just emphasizes that the washout characteristics of adenoma are not a hard and fast rule. The in-phase and out-of-phase imaging is the better way to go with them if you can do the MR. This is a malignant pheochromocytoma, which is invading via the left adrenal vein and growing toward the IVC. And MR is very good for pheochromocytoma imaging, even though the spatial resolution is a little less. It's getting much better with the breath hold sequences. As I mentioned, it's very good for bladder tumors and can also pick up the mediastinal ones. It will often look like hepatic hemangioma in terms of signal characteristics in that they're dark on T1 and extremely bright on T2 scans. Venous sampling has been used if CT and MR findings are equivocal or negative for pheochromocytomas. And here's an example of pheochromocytoma of MR here in the right adrenal gland. These are T1 weighted scans. Here you have proton density T2. Notice how bright this is. And here on heavy T2 weighted images, they still stay very bright. Adenomas would fade, metastases would fade, carcinomas would fade. MIBG has been used for imaging of the pheochromocytomas with iodine radionuclide labeling. What's nice about the MIBG scan is you can do a whole body scan in cases where you suspect the extraadrenal tumors. The accuracy is pretty good. The disadvantage is the resolution isn't as great. It can be taken up by normal adrenal medulla, depending on which isotope you use, and they take a few days to complete. But they are very good for ectopic and metastatic disease. So to move on, that takes care of our medullary imaging. Now to move on to metastatic disease of the adrenal glands. Incidence in one autopsy series was up to 27%, the most common primary tumors being from the lung and the breast. It really is a nonspecific appearance, but something to consider when you already have another primary. When less than 3 centimeter, they tend to be homogeneous. As they get larger, they can necrose, they can hemorrhage. They rarely calcify. This is a good differentiation from the other tumors we've already discussed. And on MR exam, they will frequently be isointense to fat on T2 scans. So unlike the pheochromocytoma, which stays bright, these won't be as bright. Here's an example of metastatic colon cancer involving both adrenal glands, here very large bilateral metastases. And features suggestive of metastatic disease. I'm sure you've seen plenty of mets, so I'll just go through the salient features. Large tumors, poorly defined margins, local invasion, of course presence of another primary always helps. Heterogeneous composition, thick irregular enhancing rims have all been described in adrenal metastases. Here's an example of metastatic prostate cancer involving the right adrenal gland, and this one was invading the IVC. So, to move on to other more incidental findings, let's go on to the myelolipoma of the adrenal gland, which is a rare but benign tumor that's composed of hematopoietic tissue and adipose cells. These are typically unilateral, asymptomatic, frequently just discovered incidentally. Though they can enlarge, they can get as high as 10 centimeter or more, in which case they get prone to hemorrhage and necrosis and can become painful. They're well-defined lesions, and what you're looking for is macroscopic fat. Macroscopic fat is pretty much diagnostic of a myelolipoma. Here's an example of a large myelolipoma of the adrenal gland diagnosed on ultrasound exam, as seen as a very large echogenic mass, a little heterogeneous, but this is due to the fatty component. Here's myelolipoma on CT scan. 2 different cuts of the same lesion. Here you can see, notice the signal intensity is identical to the retroperitoneal fat, or I should say the density. Here you see the soft tissue component. Here more caudally, fat density with a little soft tissue rim, clearly separate from the kidney. Lymphoma is another tumor that can involve the adrenal gland, is more commonly seen with non-Hodgkin's lymphoma, and that will give you the diffuse form. Despite extensive involvement of the adrenal glands, adrenal insufficiency is rare. What you see in lymphoma is rounded unilateral or bilateral diffuse adrenal enlargement. It can be homogeneous and enhancing. You'll often have adenopathy elsewhere, which will tip you off to the diagnosis. Here's a patient who had bilateral adrenal lymphomatous involvement. Here you can see the large masses, fairly homogeneous, involving both glands, clearly separate from the kidneys. Now moving on to adrenal hemorrhage. This is more common in neonates. It can be due to the trauma of delivery, asphyxia, septicemia, or abnormal clotting factors. Adrenal insufficiency is rare in these cases. It can occur in children and older adults as a spontaneous hemorrhage. Again, septicemia, hypertension, renal vein thrombosis, various adrenal diseases. This will more commonly affect the right gland. And as Dr. Grant mentioned, in trauma, up to 25% of severely traumatized patients can have adrenal hemorrhage, up to 25% of them. These can be bilateral, though this is less common. More commonly, it is in the right adrenal gland that you'll see it. One of the proposed mechanisms is that the elevated IVC pressures from abdominal trauma are transmitted more directly through the venous system right into the adrenal gland, whereas the left gland, by virtue of emptying into the renal vein as opposed to directly into the IVC, is slightly cushioned. It can occur in anticoagulation therapy. Usually during the first 3 weeks of therapy is when it'll happen, and it's not due to excessively high anticoagulation, it's just the fact that they're being anticoagulated. Just to point out once again, bilateral hemorrhage is uncommon and can be seen in bleeding diatheses, severe stress, can be seen in the anticoagulant therapy. But the thing with a bilateral hemorrhage that you have to remember is that it can cause an acute adrenal insufficiency that's potentially fatal. So it's important to recognize it early. So what do you look for? In the acute phase, you're going to see a hyperdense mass, 50 to 90 Hounsfield units, similar to blood. They can be up to 3 centimeters in size, and then we'll do what blood does. Gradually decrease in density over time. It'll reach near water density. It can calcify. It can resorb, just like a hematoma anywhere else in the body. You may see streaky infiltration of the periadrenal fat, as Dr. Grant showed you, and you may see enlargement of the right crus. Ultrasound can be useful to image these in children, but is not as useful in adults. It'll do just what any other hematoma does, initially echogenic, then it'll get complex hypoechoic, anechoic as it matures, and eventually, hopefully, resorb. And MR will also show signal characteristics of hematoma. So here's an example of an acute adrenal hemorrhage that was bilateral. Notice here we have both glands are rounded. They have slightly bright areas in them, slightly fuzzy margins, and this was acute adrenal hemorrhage in a trauma patient, and the patient did have adrenal insufficiency, extremely ill. This is adrenal hemorrhage of the right gland. It is 3 weeks old by history, and it is in the subacute stage, and so you can see that on the MR characteristics. Now we've got some intermediate signal on this T1 scans. Here it was an out-of-phase scan showing, as you would expect, there's no signal loss inside on the out-of-phase scans because there's no fat in there. So all that doesn't lose signal in the middle is not malignant. And bright signal on T2 scans. So all that is bright on T2 is not FEAL. This is an example of a chronic hematoma already out at 2 months. It was in the right adrenal gland. This is smaller than on the original scan, and all we have now at this point is a dark hemosiderin rim on all sequences with a bright little focus in the middle that's bright on T1, bright on T2, and this was a small adrenal hemorrhage of the right gland. Here are 2 cases of chronic, very old adrenal hemorrhage, just showing the calcification that can develop in these. Here, rim calcification in this one, central in this one, so nothing really specific about that. And then just to wrap it up, cysts are uncommon, and can occur at any age. They can be endothelial, they can be pseudocysts, they can be parasitic, they can be true cysts. They look like cysts. I'm not going to get into that. Just want to spend the last few minutes on pseudotumors. Things that can mimic adrenal masses are exophytic masses of the kidney, a little bit of colon getting up in the area, particularly on the right side, liver masses on the right, tortuous splenic masses, and gastric diverticula on the left. Splenules can mimic them, and pancreatic lesions can mimic adrenal masses. Here's a patient who looked like he had an adrenal cyst. This was definitely water density on density measurements, but if you look on another cut, you can see there's an air fluid level in it. Okay, is this an abscess? No, this was a gastric diverticulum. It did communicate with the gastric lumen, totally benign. So if you see air fluid levels, got to think about diverticula in addition to abscesses and all those other evil things. Here was another little adrenal nodule picked up in a patient who had a lung carcinoma, and they were very worried about metastasis. So we did a biopsy. Biopsy confirmed needle position was skewered this thing right through the middle, had a nice clean shot coming slightly lower through an intercostal level, got that thing, turned out to be a splenule. It was all splenic tissue. So that concludes the adrenal imaging.